How to perform bedside endoscopic retrograde cholangiopancreatography for acute cholangitis. A therapeutic duodenoscope, triple lumen sphincterotome, guide wire, and a plastic biliary stent are required for the procedure. An 88-year-old woman with a past medical history of coronary artery disease, atrial fibrillation, diabetes, hypothyroidism presented to our emergency department with one-day history of fever, abdominal pain, fatigue, nausea, vomiting, and diarrhea. On arrival, she was in septic shock and respiratory failure. Labs were notable for leukocytosis, cholestatic pattern of liver injury, and acute kidney injury. Initial management included intravenous fluid resuscitation, broad-spectrum antibiotics, vasopressor support, and mechanical ventilation. Non-contrast CT abdomen and pelvis showed a 2.2 cm stone in the common bile duct, leading to upstream dilatation of the intra- and extrahepatic biliary ducts. CBD measured 3.2 cm. There was no evidence of pancreatitis. She was diagnosed with acute ascending cholangitis and was admitted to the intensive care unit. Emergent ERCP was indicated. Due to clinical instability and operating room unavailability, patient could not be transported out of the intensive care unit. Decision was made to pursue a bedside ERCP with a stent placement without fluoroscopy. ERCP was performed within 24 hours of presentation to the emergency department. The patient was placed in the left lateral position. Propofol was administered for sedation per the intensive care unit. Therapeutic duodenoscope was used, which showed a bulging ampulla in the second part of the duodenum. The bulging major papilla was engaged with the sphincterotome, expressing sludge and debris. The guide wire was passed into the bile duct and the sphincterotome was used to cannulate the bile duct over the guide wire. A sphincterotomy was performed and the sphincterotome was removed over the guide wire. A 10 French by 7 cm plastic stent was placed 6 cm into the common bile duct. Stent position was then verified using an abdominal radiograph. No immediate procedure-related complications were seen. Since fluoroscopy is not used in this technique, other methods to ensure that biliary cannulation is successful are the following. At the beginning of the procedure, it is important to angle the sphincterotome between 11 o'clock and 1 o'clock position. The guide wire should go into the bile duct easily for at least 15 centimeters. If it does not, the cystic duct or the pancreatic duct may have been cannulated. If bile is not expressed through cannulation, aspiration from sphincterotome can provide further reassurance. Our institution has had success in performance of bedside ERCP for acute cholangitis in select patients in the ICU. From 2007 to 2012, 8 patients underwent bedside ERCP. ERCP with endoscopic stent placement was successful in 5 out of 6 patients with normal anatomy, but failed in 2 patients with altered anatomy. Rescue ERCP with fluoroscopy was required in 1 patient. There was no post-ERCP pancreatitis or procedure-related morbidity. Biliary decompression in acute cholangitis is recommended within 48 hours of presentation. Bedside ERCP is a technically feasible and useful method in critically ill patients who are unsafe to transport or where logistical hurdles such as operating room unavailability prevent a timely ERCP. Simple imaging modality such as portable X-ray can be utilized to confirm the stent position when fluoroscopy is not available. This is a video illustration of one technique of performing bedside ERCP without fluoroscopy. The goal of the technique is to intervene quickly by placing a biliary stent. Thank you.